Idiopathic thrombocytopenic purpura. Etiology. Idiopathic thrombocytopenic purpura, IDP, is immune-mediated. A circulating antibody binds to an antigen on the surface of the platelet and leads to destruction in the reticuloendothelial system, particularly the spleen. These may be directed against the glycoprotein 1b and 2b/3a complexes. Epidemiology. Similar incidence in boys and girls, commoner in women than men. Clinical presentation. Common. Ranges from few purpuric spots to extensive purpura and bleeding from mucous membranes. A history of viral prodrome is common in children, but not in adults. Many adult patients have no symptoms and the diagnosis is made incidentally when a routine FBC is performed. Uncommon. Retinal hemorrhage is usually only seen if there is anemia in addition to thrombocytopenia. Intracranial hemorrhage, which may be preceded by complaints of headache and neck stiffness. Physical signs. Apart from hemorrhage, there are usually no abnormal physical signs. Splenomegaly is not a feature. If the spleen is palpable, this suggests that the diagnosis is not IDP. Investigation. The platelet count is usually less than 50x109/L and often less than 10x109/L, when there is substantial risk of serious bleeding. FBC and clotting tests are otherwise normal. Bone marrow examination may be performed in older patients to exclude myelodysplasia and typically shows increased numbers of megakaryocytes. Platelet autoantibodies, IgG in particular, can be found, but these are not measured routinely. Differential diagnosis. Usually the diagnosis is straightforward, but is one of exclusion. IDP is defined as isolated thrombocytopenia with no clinically apparent associated disorders. Other causes of thrombocytopenia need to be considered, in particular drug-induced thrombocytopenia, systemic lupus erythematosus and HIV infection. Treatment. The aim of treatment is the prevention of bleeding, not cure of the IDP. In children, the disease is usually self-limiting and treatment is not indicated. Corticosteroids are the mainstay of treatment in adults. Prednisolone 0.51.0 mg/kg daily, producing a response in 60–70% of cases within 3 weeks. As the differential diagnosis includes acute lymphoblastic leukemia, ALL, the commonest malignancy of childhood, never start steroids without first confirming a normal bone marrow by aspirate. Both ALL and IDP may respond initially to steroids, but clearly patients with ALL will subsequently deteriorate rapidly. High-dose intravenous immunoglobulin, 0.4 g/kg daily for 3–5 days, is sometimes used in refractory cases. Splenectomy may be performed for chronic refractory IDP, but is associated with a subsequent increased risk of life-threatening infection and should be avoided if possible in children under the age of 5 years old. Patients will need vaccinations before splenectomy and lifelong prophylactic antibiotics after splenectomy. A variety of immunosuppressants has been used in refractory cases with occasional success. Platelet transfusion is used in life-threatening situations but is of limited value because transfused platelets are rapidly destroyed. Complications. The main risk is of intracerebral hemorrhage. Prognosis. In children, IDP is an acute self-limiting illness, which resolves over 1–2 weeks. In adults, a similar pattern can be seen, but the disease more often follows a relapsing or remitting course, chronic IDP. Death due to hemorrhage is rare in IDP.